Okay, welcome everyone. Today we talk about very interesting topic. Cardiology is very important in any of the steps exam, and we're going to talk about the key points for each one. Okay, so this is kind of the idea. Okay, these are ideas of questions I summarized in a line or two, so we're just going to go over them rapidly. It's a rapid review. So this first case, when you see someone came in with dyspnea after cardiac transplant, then this you think it's a rejection. So the best treatment for that, it's a biopsy. Okay, you want to do biopsy is the best way to deal with that. And the second idea of the question is like when you see blah 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 chest pain with ST segment elevation, this is a heart attack, and the treatment is angiography. The third idea, when you see blah 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 myxomatous degeneration of mitral valve with severe regurgitation to the posterior leaflet prolapse, what do you think is going on in this patient? Yeah, mitral valve prolapse, and may need treatment is a surgical mitral valve prolapse. It's for severe mitral regurg. Whenever they say severe regurg, this is, you need to repair that. And let's say when they say somebody 68-year-old woman, they say blah blah blah, a lot of information, they say hypertension with bevacizumab, then hypertension likely induced by bevacizumab. Okay, now whenever you see radiofemoral delay on the exam, what does that mean?
Coarctation of aorta.
Perfect, coarctation of aorta. Whenever you hear a right foot cool and pale sensation, muscle is intact without palpable pulses, what do you think is going on?
CAD.
Perfect, and then you need invasive angiography. Why? Because you need to intervene immediately. This is an acute critical limb ischemia. When you see no palpable pulses, this is huge. This is mean acute critical limb ischemia. Whenever you see women who have CAD with atrial fibrillation, then the treatment you can do, you can start anticoagulation, and you don't need aspirin. You can discontinue aspirin and do anticoagulation so that you decrease the risk for bleeding. Now, whenever you have someone with chronic chest pain that triggered by exercise and has abnormal EKG, and then they ask about what is the diagnostic test. So this is the key. When the chest pain triggered by exercise, this indicate coronary artery disease. When there's abnormal, when it's normal EKG, you do just exercise stress EKG. But if there's abnormal EKG, then EKG wouldn't be useful. So you do exercise stress echocardiography. Okay, so that's the difference. Here, there is another idea of a case when you say 48-year-old man with a 6-week history of fatigue, dyspnea on exertion, JPD, pericardial friction. What do you think is going on? What's the diagnosis?
Pericarditis.
Yeah, and then you treat that with ibuprofen and colchicine. Whenever you see 80-year-old woman who have 6-month history of worsening dyspnea and stroke volume is low and mean aortic gradient is 20 and aortic valve area it's 0.7 and there's severe stenosis. Okay, they told you severe aortic stenosis. Okay, what would be the best next step for this patient?
That's surgery. Remove the valve.
Yeah, and then before you remove it, you can do a test like for severe aortic stenosis. You can do dobutamine echocardiography. Okay, let's move to a different question idea. Let's see 75-year-old woman with dyspnea, edema, hypotension, and cold extremities. So what do you, and 20% ejection fraction. Okay, so what is the diagnosis and how do you treat it?
Congestive heart failure.
Yeah, this is cardiogenic shock. How do you treat that?
Okay, so we treat it with the ionotropic. What are the inotropic? Is it
Dobutamine, yeah, dobutamine would be a good inotropic agent for cardiogenic shock.
What else is?
Norepinephrine is a good one too as well, but dobutamine usually is used more commonly in cardiogenic shock. Okay, now we.
Digoxin and the other one is not, right? The
Huh?
Digoxin.
No,
and,
no. Digoxin is for outpatient. It's not for inpatient setting who's almost dying. This lady is dying. It's not used. Not digoxin. Maybe after they resolve, you can send them on digoxin as an outpatient. It's a pill and stuff. This is a drip pressor. When you have 78-year-old with palpitation, fatigue, exercise intolerance, and recurrent atrial flutter on EKG. So the way you want to manage that patient with what do you want to manage that patient who have palpitations and recurrent atrial flutter?
Oh, so flutter is a ablation?
Yeah, exactly. That's correct. When you have continuous murmur beneath the left clavicle, what does that tell you?
Machinery murmur. Oh, I'm sorry. Patent ductus.
PDA, patent ductus arteriosus. Whenever you see continuous murmur, this is a patent ductus arteriosus. When you have women with exertional dyspnea for several weeks and ST depression with anterior wall perfusion defect, what does that tell you? And normal coronary artery. What's your diagnosis for this patient?
ST depression with a mild anterior wall.
So whenever you see this idea in the exam, it's just like, I'm giving you new ideas. So whenever you see ST depression with normal, and then anterior, there is perfusion defect, but there is a normal coronary artery. This is on cath. Just remember that it's cardiac syndrome X. You may or may not get asked about it. It's not very common, but just something to keep in mind, okay? And we can dig deep in the physiology later.
Stress?
Huh?
Is this the one that caused by stress?
No. This other one is called Takasubo cardiomyopathy. They have heart failure symptoms. Okay. This one have coronary artery disease symptoms, and they have these things. Okay, we'll dig deep in the physiology later, but this one is just like to have a nice summary, just focusing on the clues, like just to memorize, have improve test taking strategies whenever you remember something. So there is 56-year-old woman with 6 months of progressive cough after walking and diminished femoral and popliteal pulses. So what does that tell you? How do you treat this patient?
But this is like there's a clot emboli there.
No, so there's discomfort, progressive discomfort after walking, okay, and diminished pulses. This is a peripheral arterial disease.
Yeah, that's true. Sorry.
Okay, so you do a supervised exercise program. Emboli, they will tell you, okay, there's a swelling and there's history of travel, surgery, stuff like that. Okay, when you see aortic aneurysm of 6.2, what do you do? What do you do? Best next step?
If the ultrasound shows that, oh yeah, I should do CTA. Sorry.
You do CT so that you possibly operate. So this is an easy question. They give you a patient with LDL of 131. What's increased risk for cardiovascular disease? Hyperlipidemia. That's why we give statin. Anyway, another easy case. Someone who come in with a 25 EF and left ventricular end diastolic diameter of 6.7. Okay. Whenever you see that, and there is no JVD, S3 or edema, so someone have heart failure, but they are not acutely decompensated. They're well decompensated. He's stable. Okay. And comes in for a routine visit. The answer: what would you do for him?
Why we have to do a kidney function?
Just do CBC BMP. You know, just like regular BMP.
Oh, okay.
Okay, got it.
Yeah, because in future if you need a furosemide and stuff, right?
So 20 we usually do them even if someone doesn't have much, just your routinely. So now we have a lady, the young lady with intermittent palpitation, an episode of dyspnea and lightheadedness, okay, that last 30 to 90 minutes and had similar episode of SVT in the past. Okay, what would you do for this patient? What's the best next step?
Okay, so that maybe is a what I call the pheochromocytoma. Oh, AFib?
No, so this one could be Wolff-Parkinson-White syndrome because they have intermittent palpitation. Whenever you see this encounter, intermittent palpitation, dyspnea, lightheadedness, that lasts from 30 to 90 minutes. Okay, this make you think that it could be Wolff-Parkinson-White syndrome. So how do you diagnose that? You do electrophysiology study, okay? You gotta understand, because there's some sort of arrhythmia, okay? Because echo is normal and they have these symptoms, okay? This makes you concerned. Palpitations, dyspnea, shortness of breath, that come and go. Come 30 minutes and go. This makes you concerned of something, okay? Now, when you have a young lady with Marfan and dilated proximal descending aorta with dimension of 4.6 centimeter, okay? Asking about pregnancy. So what would you advise this lady? Do you tell her go ahead, have a baby, or tell her no, it's not, unfortunately you cannot?
Okay, so it has a dilation of aorta. Oh, really?
Yes. Yeah, these ladies, like, unfortunately, it's hard. I wouldn't recommend I wouldn't recommend being pregnant because they could die. You know, pregnancy is a physiologically challenging to the body. I would say it's extremely demanding. You need increased cardiac output. You need all these things. So this could rupture with a pregnancy. So I would advise not to get pregnant. So we have no, this is another idea. Someone have 3-hour transient right arm pain and weakness. Okay. So what does that tell you? 3-hour transient arm weakness. Okay, you're doing a neurology. What does that tell you? Possible stroke, right? And then echo shows papule in the endomyocardium. What does that tell you? What is the diagnosis? So this is just something, remember, you know, something like whenever you see,
I've never heard of it.
yeah, or a myxoma or something like that. There's some heart tumor that could break down and shoot up to the brain and clog some arteries, okay?
Okay.
Okay, now let's have, we have this middle-aged woman came with Eisenmenger syndrome, okay? Came in with digital clubbing and central cyanosis and low hemoglobin. How do you treat this lady? How do you treat her anemia? Yeah, you give her some iron, okay? Now we have middle-aged man who's epigastric discomfort and nausea, okay? They began 45 minutes ago and ST segment elevation. What is your diagnosis? Heart attack, yeah. You should never miss this thing. This is lethal, and that's the thing that you never want to miss. But the ST elevation 2-3 AVF, what type of heart attack?
It's the inferior part of the lung.
Okay, and now the patient came in within 4 hours. What would you treat with?
Oh, it's too late for the PCI to give it TPA.
No, it's actually early so you can do so you can do TPA. It would be a good option. So we have this elderly man with cough and foot pain, and with ABI more than 1.4. Okay, this is a kind of a harder question. Left cough actually, and foot pain that have faint and ABI greater than 1.4. The way you want to handle that is by toe brachial index to diagnose peripheral arterial disease, because the ABI is inconclusive. So you can do, if the ABI didn't help you, then you do toe brachial index to diagnose PAD. So this is one thing also you add to the memory card.
Also, you narrow it down. So right ankle brachial.
Yeah. Good job. Yeah. We have this young lady that came in 8 days ago due to fever, dyspnea, fever, chills. What does that tell you? Whenever you...
Pneumonia.
Could be pneumonia, could be endocarditis, could be anything. So echo shows vegetation, so that tells you, what is it?
Oh, that's endocarditis.
And febrile after 8 days of antibiotics. So antibiotics didn't help, okay? And there's still crackles, diastolic decrescendo, murmur. What would you do to this lady?
So, sure, bilateral crackle, echo, but cardiac valve surgery?
Yeah, because if it's vegetation more than 12, this indicate possibility. You need one of the indications of surgery for endocarditis is the vegetation more than 10. Okay.